You're listening to Who Said, a Cardiology Board Review series. No fluff, just facts.
This episode is about aortic valve replacement. We'll talk about timing of intervention and who qualifies for replacement. Then we'll talk about TAVR. Then we'll talk about TAVR versus SAVR. And we'll finish with a few other details. Let's start about timing of intervention and who qualifies. There's no question that AV replacement is indicated in symptomatic severe AS, which is AS that has a Vmax of more than 4 meters per second, inclusive, aortic valve area of 1.0 centimeters or less, or a mean pressure gradient of 40 millimeters of mercury or more. In patients with asymptomatic severe AS, AV replacement is indicated if there is either concomitant cardiac surgery or one of these other 6 factors: LV ejection fraction less than 50%, decreased exercise tolerance or fall in systolic blood pressure on exercise testing, critical AS with peak velocity of 5 meters per second, systolic PA pressure of more than 60 millimeters of mercury confirmed by right heart catheterization, severe aortic valve calcification with a rate of valve stenosis progression more than 0.3 meters per second per year, or markedly elevated B-natriuretic peptide confirmed with repeat tests. Let's take a look at the exact wording on indications for aortic valve replacement from the 2020 ACC/AHA guidelines on the management of patients with valvular heart disease. And here we're talking about aortic valve replacement of any sort. We're not being specific to TAVR or SAVR, just aortic valve replacement, full stop. In adults with severe high gradient aortic stenosis, stage D, and symptoms of exertional dyspnea, heart failure, angina, syncope, or pre-syncope by history or exercise testing, AV replacement is indicated. That's a class 1 recommendation. Of course, okay? So that one's the most obvious one because they are symptomatic. But what about asymptomatic patients? This is when it gets interesting. In asymptomatic patients with severe AS and LV ejection fraction less than 50%, stage C2, AV replacement is indicated, class 1. In apparently asymptomatic patients with severe AS, stage C1, and low surgical risk, AV replacement is reasonable when an exercise test demonstrates decreased exercise tolerance, normalized for age and sex, or a fall in systolic blood pressure of at least 10 millimeters of mercury from baseline to peak exercise, class 2A. In asymptomatic patients with very severe AS, defined as an aortic velocity of at least 5 meters per second and low surgical risk, AVR is reasonable, class 2A. So this is the one about the critical AS velocity of 5 meters per second or more. In apparently asymptomatic patients with severe AS, stage C1, and low surgical risk, AV replacement is reasonable when the serum B-type natriuretic peptide, BNP, level is more than 3 times normal, class 2A. In asymptomatic patients with high gradient severe AS, class C1, and low surgical risk, AV replacement is reasonable when serial testing shows an increase in aortic velocity of at least 0.3 meters per second per year, class 2A. In asymptomatic patients with severe high gradient aortic stenosis, stage C1, and a progressive decrease in LVEF on at least 3 serial imaging studies to less than 60%, AV replacement may be considered, class 2B. In asymptomatic patients with severe AS, stage C1, who are undergoing cardiac surgery for other indications, AV replacement is indicated, class 1. What about low flow, low gradient aortic stenosis? The 2020 valve disease guidelines say in symptomatic patients with low flow, low gradient severe AS with reduced LV ejection fraction, stage D, AV replacement is recommended, class 1. In symptomatic patients with low flow, low gradient severe AS with normal EF, stage D3, AV replacement is recommended if AS is the most likely cause of symptoms, class 1. Lastly, what about moderate aortic stenosis? Is there any way that moderate AS can qualify for replacement? The 2020 valve disease guidelines say in patients with moderate AS, stage B, who are undergoing cardiac surgery for other indications, AV replacement may be considered. That's a Class 2B recommendation. The above criteria are for aortic valve replacement of any kind. In the next one third of this episode, I will focus on TAVR specifically. And then in the final third of the episode, I will go over the decision making approach for TAVR versus SAVR. TAVR has revolutionized the treatment of aortic valve disease in the last 2 decades. As a bonus, I'm adding a few details that are not going to be tested on the General Cardiology Board exam, but that will be useful to know in practice. What are the available valves? There are several valves available for TAVR. The vast majority of centers in the US use either Edwards Sapien family or the Medtronic core valve Evolute family. The Edwards family includes the Sapien 3 of 2015, Sapien 3 Ultra of 2019, Sapien 3 Ultra Resilia of 2024. These are balloon expandable and intraannular. The Medtronic core valve family includes the Evolute R 2015, Evolute Pro of 2017, Evolute FX Plus of 2024. These are all self-expanding valves instead of balloon expandable valves of Edwards, and they are supraannular instead of the intraannular valves of Edwards. Then you have Abbott Portico 2019 and Navitor 2023, which are self-expanding, just like Medtronic, and they are intraannular, which is more like Edwards rather than Medtronic. There's also Boston Scientific's Lotus, NVT's Allegra, Cementis Accurate Neo, and Accurate Neo 2. These systems have received CE mark approval in Europe, but not approved in the US yet at the time of recording in 2024. Cow pericardial tissue is used for the Edwards Sapien family, Abbott Portico, and Boston Scientific's Lotus. On the other hand, pig pericardial tissue is used for the Medtronic Evolute family and the Cementis Accurate Neo. How do they work? There's balloon expandable mechanisms and self-expanding types. For balloon expandable valves, such as the Edwards Sapien valve, it is compressed and placed over a balloon just like a coronary stent is. When it is advanced to the correct position, the balloon is inflated, expanding the stent frame until it holds onto the patient's aortic annulus. Once it is inflated in position, it is irretrievable. The Sapien 3 Ultra provides a longer, coarser skirt compared to the Sapien 3 in order to reduce paravalvular leak. The drawback of the balloon expandable approach, Edwards Sapien, is higher risk of aortic annulus rupture and higher risk of coronary artery obstruction compared to the self-expanding valve approach of Medtronic. The Medtronic core valve Evolute family, which is a self-expanding valve, is advanced to the level of the aortic annulus wrapped in a sheath. As the sheath is slowly retracted, the valve frame inside expands in place. Hence, it is called self-expanding. In contrast to the balloon expandable valve of Edwards, it is possible to recapture the valve if the self-expanding valve is malpositioning observed early in its deployment. The Medtronic core valve Evolute Pro provides an outer skirt in the ventricular position to reduce paravalvular leak. The drawback of the self-expanding approach for a Medtronic core valve Evolute is much higher risk of needing a permanent pacemaker. What are the arterial vascular approaches to TAVR? Transfemoral approach is the most common, whereby the delivery sheath is advanced from the common femoral artery up to the descending aorta over the aortic arch to the aortic root. Transapical through a small left thoracotomy is very rarely used. Transaxillary is sometimes done. What tests do you need to order prior to TAVR? A TTE to assess the severity of AS. You don't really need a TEE for aortic stenosis. CT TAVR protocol, which refers to the aortic root, aorta, and peripheral vasculature. Left heart catheterization to assess if combined SAVR CABG or PCI pre and post TAVR is needed. Sometimes PFTs, pulmonary function tests, in high risk patients who may have obstructive or restrictive lung disease. And sometimes carotid Doppler ultrasound to evaluate for stroke risk. Okay, now back to testable knowledge. Who is excluded from getting a TAVR? Those with life expectancy less than 1 year due to non-cardiac factors such as metastatic cancer, Those with aortic annulus size less than 17 millimeters or more than 29 millimeters, since currently available TAVR valve size do not exceed this range. Those with low coronary artery takeoff, because that can lead to coronary obstruction from sinus sequestration. Endocarditis, because devices should not be implanted in the setting of active infection. And those with unicuspid or non-calcified aortic valves. Patients with the following relative contraindications have either been excluded from trials or not thoroughly studied, but these factors do not necessarily preclude getting a TAVR and may be eligible in coming years. Need for AV replacement on an emergent basis, recent myocardial infarction in the last 30 days, recent cardiogenic shock in the last 30 days, recent stroke, hypertrophic cardiomyopathy, LV ejection fraction less than 20%, severe RV dysfunction due to pulmonary hypertension, severe dementia, severe mitral regurgitation, bicuspid aortic valves, and severe aortic regurgitation. These are the, quote, relative contraindications of patients who either have been excluded from trials or not thoroughly studied yet. It's important to know about complications, as patients will often ask you that in the shared decision making. What are the intra-procedural complications of TAVR? There's severe acute structural complications. The incidence of annulus rupture, chamber perforation, valve embolization, and need for cardiopulmonary bypass support and conversion to open heart surgery are less than 0.5% each, according to the 2020 TVT registry. Coronary obstruction. The risk of coronary obstruction can be estimated by measuring the coronary orifice height above the aortic annulus, the size of the sinuses of Valsalva relative to the annulus, and the size of the aorta relative to the type and size of the planned valve. In one registry, preemptive wiring was used in 2.2% of TAVR cases. These were deemed high-risk cases, followed by coronary stent deployment in 61% of these cases. Now, there's also access-related vascular complications. Transfemoral access-related vascular complications occur in 1.5%. The incidence has decreased over the years due to the use of ultrasound-guided common femoral artery access and use of suture-based vascular closure devices. What are the post-procedural complications of TAVR? Well, there's need for pacemaker due to high degree AV block. This occurs in 6% of balloon expandable valves, such as Edwards, and 17% of self-expanding valves, such as Medtronic, with an overall national rate of 11% among TAVR. It occurs due to trauma to the membranous septum. There's bleeding, which occurs in 5% of patients, stroke, which occurs in 2% of patients. Although cerebral embolic protection during TAVR is FDA approved, the evidence that it works is mixed. There's acute kidney injury, which occurs in 1%, and endocarditis in less than 1%, which is the same frequency as after SAVR. What are the long-term complications? There's paravalvular regurgitation and patient prosthesis mismatch. Paravalvular regurgitation, moderate to severe PVR, occurs in 1.5% of patients after TAVR. The incidence has decreased over the years due to improvements in CT-based assessment of annular dimensions to optimize valve size, newer generation valve designs which incorporate external wraps to fill gaps and promote flush contact with the annulus, and intra-procedure recognition of PV regurgitation and use of post-dilation strategies. Then, for patient prosthesis mismatch, moderate PPM occurs in 25% of patients after TAVR long-term. Severe PPM occurs in 12%. This is the condition where the effective orifice area of a normally functional prosthesis is too small in relation to the patient's body size, leading to higher mortality and heart failure rehospitalization. How to diagnose PVR and PPM is covered in a subsequent episode. What anticoagulation or antiplatelet therapy should patients be on post-TAVR? The short answer is only aspirin, because recent studies suggest that only aspirin may be as effective as DAPT. If the patient is at low risk of bleeding, you can do DAPT, aspirin, and clopidogrel for 3 to 6 months, but it's not really necessary. If they are already on an anticoagulant for other reasons, such as a DOAC for AFib, then there is no need to add clopidogrel on top of that, based on the results of the popular TAVI trial. The point of anticoagulation or antiplatelet therapy is to prevent hypoattenuating leaflet thickening, halt, reduced leaflet motion, and hypoattenuation affecting motion, or HAM. What do the 2022 AHA ACC valvular heart disease guidelines say? For patients with a bioprosthetic TAVI, aspirin 75 to 100 milligrams daily is reasonable in the absence of other indications for oral anticoagulants. That's a class 2A recommendation. For patients with a bioprosthetic TAVI who are at low risk of bleeding, dual antiplatelet therapy with aspirin 75 to 100 and clopidogrel 75 milligrams may be reasonable for 3 to 6 months after valve implantation, class 2B. For patients with a bioprosthetic TAVI who are at low risk of bleeding, anticoagulation with a VKA such as warfarin to achieve an INR of 2.5 may be reasonable for at least 3 months after valve implantation, class 2B. For patients with bioprosthetic TAVI, treatment with low-dose rivaroxaban 10 milligrams daily plus aspirin 75 to 100 milligrams daily is contraindicated in the absence of other indications for oral anticoagulation, class 3 harm. Now we'll move on from TAVR to talk about the decision making for TAVR versus SAVR. In this episode, I will try to provide a systematic overview of different factors, starting with age and life expectancy. TAVR is favored if older age, especially more than 80 years old, and or shorter life expectancy. In contrast, SAVR is favored if it's younger age, especially less than 65 years old, and or longer life expectancy. Palliation is favored if older age, and limited life expectancy. Next, valve anatomy. TAVR is favored if there is severe calcific aortic stenosis of a tri-leaflet valve. SAVR is favored if there is bicuspid aortic valve, subaortic calcification in the left ventricular outflow tract, rheumatic valve disease, or small or large aortic annulus beyond the existing size of valves. Next, prosthetic valve preference. TAVR is favored if a bioprosthetic valve is preferred, and we'll go over bioprosthetic versus mechanical shortly after this. TAVR is also favored if there's a favorable ratio of life expectancy to valve durability. TAVR provides large valve area compared to the same size SAVR. On the other hand, SAVR is favored if the patient prefers a mechanical or surgical bioprosthetic valve, or if there's a patient prosthesis mismatch concern. Then how about concurrent cardiac conditions? TAVR is favored if there's severe calcification of the ascending aorta, which is what we call porcelain aorta. SAVR is favored if there's aortic dilation, severe primary mitral regurgitation, severe CAD requiring CABG, or septal hypertrophy requiring myectomy. Palliation is favored if there's irreversible severe LV systolic dysfunction, or severe MR attributable to annular calcification. Then how about non-cardiac conditions? TAVR is favored if there's severe lung, liver, or kidney disease, or mobility issues that can increase post-procedural risk of sternotomy. SAVR is favored if there's actually no items in this category, so let's skip that. Palliation is favored if symptoms are likely attributable to non-cardiac conditions, or if there's severe dementia or moderate to severe involvement of at least 2 other organ systems. Now, how about frailty, especially in older adults? TAVR is favored if frailty is likely to improve after TAVR. SAVR is favored if the patient is not frail. Palliation is favored if severe frailty is unlikely to improve after TAVR. Then, how about the estimated procedural or surgical risk? TAVR is favored if the TAVR risk is low to medium and the SAVR risk is high. SAVR is favored if the SAVR risk is low and the TAVR risk is high. Palliation is favored if there's a prohibitive SAVR risk, more than 15% mortality, or post-TAVR life expectancy is less than 1 year. Now, how about procedure-specific impediments? TAVR is favored if there's previous cardiac surgery with at-risk coronary grafts or previous chest irradiation. SAVR is favored if there's valve anatomy, annular size, or low coronary ostial height that precludes TAVR, or if vascular access does not allow transfemoral TAVR. Then, it's also important to consider goals of care and patient preferences and values. TAVR and SAVR are for individuals who prefer life prolongation, symptom relief, and improved long-term exercise capacity and quality of life, whereas palliation is for individuals who feel that life prolongation is not an important personal goal and who are wanting to avoid futile or unnecessary procedures. It's for patients who are wanting to avoid procedural stroke risk and avoiding the possibility of a cardiac pacemaker. Among those who are not going for palliation as part of the goals of care, then between TAVR and SAVR, TAVR is for individuals who are accepting of the uncertainty of valve durability and possibility of repeat intervention, accepting of the high risk of permanent pacer, and preferring a shorter hospital stay with less post-procedural pain. Whereas SAVR is for individuals who prefer avoiding repeat intervention, lower risk of permanent pacemaker, avoiding vascular complications, and accepting of a longer hospital stay with a greater pain in the recovery period. What do the guidelines say about TAVR and SAVR? As of the time of this recording in 2024, the latest guidelines available on the topic of choosing TAVR versus SAVR are the 2020 AHA-ACC guidelines on the management of patients with valvular heart disease published in 2021. The guidelines offer several points, all of which are Class 1 recommendations except for one. For symptomatic and asymptomatic patients with severe AS and any indication for AV replacement who are less than 65 years of age or have a life expectancy more than 20 years, SAVR is recommended. That's a Class 1 recommendation. For symptomatic patients with severe AS who are 65 to 80 years of age and have no anatomic contraindications to transfemoral TAVI, either SAVR or transfemoral TAVR is recommended after shared decision-making about the balance between expected patient longevity and valve durability, Class 1. For symptomatic patients with severe AS who are more than 80 years of age, and for younger patients with a life expectancy of less than 10 years and no anatomic contraindication to transfemoral TAVI is recommended in preference to SAVR, Class 1. Now, how about asymptomatic patients? In asymptomatic patients with severe AS and an EF less than 50% who are 80 or lower years of age and have no anatomic contraindication to transfemoral TAVI, the decision between TAVI and SAVR should follow the same recommendations as symptomatic patients in the first three categories, Class 1. For asymptomatic patients with severe AS and a normal exercise test, very severe AS, rapid progression, or an elevated BNP, these are class of recommendation 2A indications of AVR. SAVR is recommended in preference to TAVR, Class 1. For patients with an indication for AV replacement for whom a bioprosthetic valve is preferred, but valve or vascular anatomy or other factors are not suitable for transfemoral TAVR, SAVR is recommended, Class 1. For symptomatic patients of any age with severe aortic stenosis and a higher prohibitive surgical risk, TAVR is recommended if the predicted post-TAVR survival is more than 12 months with an acceptable quality of life, Class 1. Almost there, second last one. For symptomatic patients with severe AS for whom predicted post-TAVR or post-TAVR survival is less than 12 months, or for whom minimal improvement in quality of life is expected, palliative care is recommended after shared decision-making, including discussion of patient preferences and values, Class 1. In critically ill patients with severe AS, percutaneous aortic balloon dilation may be considered as a bridge to SAVR or TAVR, Class 2B. This is the only recommendation that's a non-Class 1 recommendation in this section of the guidelines. So we talked about TAVR versus SAVR, and I promised that I would mention something about bioprosthetic versus mechanical valves. Bioprosthetic valves are favored in individuals aged 65 and higher because the incidence of structural deterioration from bioprosthesis is more acceptable. The 15-year risk is less than 10% for age more than 70 years, in the context of the number of years the old patient has left to live. Older patients are at higher risk of complications of anticoagulation that would be strictly required by mechanical prosthesis. That's why bioprosthetic valves are favored in age 65 or higher. Meanwhile, mechanical valves are favored in age 50 or lower because bioprosthesis has an increased incidence of structural deterioration, the 15-year risk of 30% at age 40, 50% at age 20, requiring a reoperation during the young patient's lifetime. Young patients are at lower risk of complications of anticoagulation that would be strictly required for mechanical prosthesis. What do the 2020 valvular disease guidelines comment on the choice on mechanical versus bioprosthetic aortic valve replacements? For patients of any age requiring AV replacement for whom VKA anticoagulant therapy, i.e. warfarin, is contraindicated, cannot be managed appropriately, or is not desired, a bioprosthetic AV replacement is recommended. That's a Class 1 recommendation. For patients less than 50 years of age who do not have a contraindication to anticoagulation and require AV replacement, it is reasonable to choose a mechanical aortic prosthesis over a bioprosthetic valve, Class 2A. In patients more than 65 years of age who require AV replacement, it is reasonable to choose a bioprosthesis over a mechanical valve, Class 2A. For patients 50 to 65 years of age who require AV replacement and who do not have a contraindication to anticoagulation, it is reasonable to individualize the choice of either mechanical or bioprosthetic AV replacement with consideration of individual patient factors and after informed shared decision making, Class 2A. In patients less than 50 years of age who prefer a bioprosthetic AV replacement and have appropriate anatomy, replacement of the aortic valve by a pulmonic autograft, the Ross procedure, may be considered at a comprehensive valve center. That's a Class 2B recommendation. Those are what the 2020 valvular disease guidelines say about the choice of mechanical versus bioprosthetic aortic valve replacement. Now, I want to say a few more points. I'll touch upon balloon valvuloplasty. Percutaneous aortic valve balloon dilation, which has an important role in treating children, adolescents, and young adults with AS, has almost zero role in treating middle-aged and older adults with AS, unlike its major role in treating adults with MS, mitral stenosis. The mechanism by which balloon dilation modestly reduces the severity of stenosis in older patients is by fracturing calcium deposits within the valve leaflets and, to a minor degree, stretching the annulus and separating the calcified or fused commissures. Although there is an immediate moderate reduction in the transvalvular pressure gradient, the post-dilation valve area rarely exceeds 1.0 centimeters square, so has limited effect. There's early, modest symptomatic improvement with a modest improvement, i.e. re-enlargement in the valve area. However, serious acute complications occur within 6 to 12 months in most adults who undergo percutaneous aortic balloon dilation, including severe aortic regurgitation, restenosis, and clinical deterioration. Therefore, in adults with AS, percutaneous aortic balloon dilation is not done, except in very rare situations. You kind of just want to go and make the decision TAVR or SAVR. In terms of prognosis, among asymptomatic severe AS patients with aortic velocities more than 4 meters per second at baseline, only 47% remain free of death or aortic valve replacement at 2 years. Only 33% remain symptom-free at 5 years. If someone has enough atherosclerosis to require CABG, their AS is also going to progress faster. That's one of the reasons that we allow moderate AS to be replaced if somebody is undergoing concomitant CABG instead of waiting for severe. I hope that was informative. So we've covered timing of aortic valve replacement, TAVR details, the decision between TAVR versus SAVR, the decision between bioprosthetic and mechanical valves, and briefly balloon valvuloplasty. Stay tuned for the next episode on aortic regurgitation.
This podcast is intended for qualified healthcare professionals and is designed for training purposes only. These materials should not be used for direct patient care or as a substitute for independent clinical judgment. For more educational content or to submit suggestions, visit www.rehu.com/meded.